Nail anatomy is important in understanding the imbalances that present on the nail. So let's go through a review. What we commonly refer to as the nail is actually called a nail plate. It's keratin rich. In fact, it's comprised of a number of different keratin materials. Keratin is a protein that contains a high number of sulfur amino acids. The nail plate also contains the full complement of essential elements, including zinc, selenium, magnesium, calcium, iron, and copper. Now, just from that information alone, we can infer that a deficiency in protein, or specifically sulfur amino acids, or a deficiency in any of those minerals will present with changes on the nail. And indeed, that's what happens. Likewise, we can actually see toxicity of certain elements present in nail changes. So classically, we can see the Mies lines and arsenic toxicity. We can see the whitening and selenium toxicity. We can also see evidence of hemochromatosis or iron overload in nail changes. So in addition to the nail plate, this white proximal moon-like area is called the lunula. The lunula is the most distal point of the matrix, and the matrix provides the cells, the keratinocytes, that comprise the nail plate. Just distal to the lunula is the nail bed, and this is a vascular-rich area where the nail plate is adhered. The peritechia surrounds the nail plate. They're the lateral folds and the proximal fold. This is the most distal nail free edge, and underneath the nail is the hyponychium. And the hyponychium is a sealed surface from the epidermis to the nail plate that just inhibits the entry of foreign material. Likewise, the eponychium, or the cuticle, does the same on the surface, on the dorsal surface of the nail. So the first area of investigation in the nail physical exam is the shape. And you can see Nicole's shape is curvilinear, as it should be, and the surface is smooth. Shape changes associated with nutrient imbalances or various pathology are relatively common. And one of the best known shape change is koilonychia, which is a spooning of the nail. So rather than the convex surface that you see, it actually becomes concave, as the picture shows. Koilonychia, we learn in medical school, is iron deficiency anemia. However, koilonychia is also found in zinc deficiency, sulfur protein deficiency, B vitamins, and C deficiency. If we're concerned about a deficiency of any of these nutrients, or say, for example, iron, think about other physical exam investigations you can make. We might look at the conjunctiva, we might look at the tongue, evidence of glossitis, and check the pulse. Additionally, in the nail exam, a pale nail bed can suggest iron deficiency anemia. Conditions associated with koilonychia include diabetes, which maps to communication on the matrix. Also, solvent exposure, specifically petroleum solvents, can result in koilonychia. So that would map over to biotransformation and elimination. You should be able to glean whether or not they've sustained solvent exposure of that nature from their health history. In defense and repair, koilonychia can be found in systemic lupus erythematosus as well as Raynaud. So if you're concerned about SLE, make sure that you palpate the joints, specifically the proximal interphalangeal joints, the metacarpal phalangeal joints, and also the wrist. If you notice any inflammation and tenderness, that might tip you off to looking for SLE, and then obviously look for the malar rash. In Raynaud, we might expect to find in later stage Raynaud inflammation around the peritechum. You may see evidence of ulceration. You also might notice cyanosis, hyperemia, or just simply white blanched tissue. Another shape finding that is encountered in clinical practice is clubbing. Hippocrates first described clubbing, and so sometimes it's referred to as Hippocrates' fingers. Clubbing appears, as the name implies, like a club. So the distal portion of the finger is enlarged. Sometimes they've been called drumstick fingers. Clubbing can be caused by a number of different systemic issues, most commonly pulmonary disease, such as cystic fibrosis or cardiovascular disease. So the way that we can identify clubbing in our practice is really quite straightforward. We're looking for the absence of Shamroth's window. Shamroth's window is identified by placing the two forefingers, dorsal surface, together and pressing the nail plate and the proximal nail fold together. So if you look up close at my nails, you can see there's just a slight window in there. So I indeed have Shamroth's window. There's no clubbing. So when that angle, which is approximately 160 degrees between the nail plate and the nail fold, is absent, that demonstrates clubbing. Causes of clubbing present themselves in all nodes of the matrix. So for instance, in assimilation, you might see clubbing in inflammatory bowel disease, celiac disease, and as I already mentioned, pulmonary disease, particularly cystic fibrosis. If we look in defense and repair, mercury toxicity, arsenic toxicity, and alcohol toxicity can all present with clubbing. If we look in defense and repair, cancer and certain autoimmune disease show up with clubbing. In nutrient deficiencies, interestingly, severe iodine deficiency, as seen in cretinism, can present with clubbing. The next aspect of the physical exam of the nails is just looking at color changes. Changes to color is called chromonychia, and there are a number of different causes of it. Brown vertical lines can present in melanoma. They can also present with B12 deficiency, vitamin D deficiency, and an Addison disease. The lunula, as we talked about earlier, the most distal portion of the matrix, can also have color changes. A bluish hue to the lunula suggests copper toxicity, silver toxicity, or mercury toxicity. Now the complete absence of the lunula can suggest protein deficiency, as we talked about earlier. Other color changes are called leukonychia, or the white spots. Now, there's a couple of types of leukonychia, and they're caused by a variety of reasons. So the first leukonychia is, we refer to them as Mies lines, and they're transverse white lines arising over the nail plate. Mies lines are classically associated with arsenic toxicity. But we can also see these same lines show up in zinc deficiency, protein, selenium deficiency. In fact, even selenium toxicity can show up with white transverse lines. So leukonychia striata is interesting because it's actually white transverse lines present on the nail bed, and that marks severe hypoalbuminemia. You might see that in nephrotic syndrome. The way that we differentiate leukonychia on the nail plate versus on the nail bed is simply by blanching the nail. So in leukonychia striata, if you blanch the nail, the white lines on the nail bed will disappear. However, leukonychia that's present on the nail plate will remain. Other color changes we might see in the nail include splinter hemorrhages. Now, we learned about splinter hemorrhages in medical schools related to subacute bacterial endocarditis, but you also might see them in vitamin C deficiency. In fact, if you also notice subungual hematoma, or if there's a history of subungual hematoma, bleeding gums, that would flag me to the potential for a subclinical scurvy. Splinter hemorrhages can also present when there's been trauma. In fact, leukonychia can as well, and you need to be able to distinguish between that. So when you see leukonychia or splinter hemorrhages present only on one nail or a couple of nails on the dominant hand, which is commonly used, you suspect trauma first, and then inquire with the patient as to whether or not they recollect it. If you notice that the trend continues onto the other hand. If you see them on the toes, then your index of concern jumps considerably for some of these other conditions that I've mentioned. So the next aspect of the nail physical exam is looking at the texture. Texture can change in a number of different conditions and nutrient deficiencies. Today I'm going to focus on trachyonychia, also called toenail dystrophy. Trachyonychia presents most commonly in atopic dermatitis, psoriasis, and psoriatic arthritis. The clinical presentation of trachyonychia can vary. So we can see pitting on the nails, we can see thickening or flaking of the nails. We can see ankylosis, which is actual separation of the nail plate from the nail bed. We can see a brass hammered appearance, and we can also see rough nails. Now, tying this back to the matrix, I want to point out that psoriasis and psoriatic arthritis are potently epigenetically triggered conditions. They're associated with alcohol intake, caffeine, gluten intolerance, and stress, to name a couple of triggers. Trachyonychia, or some of these nail texture changes, can be seen in protein deficiency, may be associated with mineral deficiency, and B vitamins. Growth of the nail is also considered. As you know, the nails are completely renewed in adults in about 6-month time. It might be a little bit slower for the elderly, or those with significant nutritional insufficiencies, or those with illness. Conversely, in children, nails grow much faster. They turn over completely in about 3 months' time. Now, the toes are much longer. In the typical adult, the toes turn over completely in a year's time. Again, about half that time in children, and potentially longer in elderly or those with deficiencies. Growth changes, such as brittle nails or soft nails, can alert us to nutrient deficiencies such as biotin, magnesium. General malnutrition can result in soft nails, or specifically protein deficiency. Now, as I said in the introduction, when we see these kinds of nail changes, brittle, soft, flaking changes, in your postmenopausal patient, think about osteopenia and osteoporosis. And also, as I mentioned, as you successfully treat those metabolic bone conditions, you should see the changes reflected in the nails. Bow's line is probably a concept that you remember, a name you remember from medical school. A Bow's line is a transverse canal or furrow through the nail at any point, demarcating an acute illness. The degree of the furrow or the canal suggests the degree of the illness. Incidentally, a diarrheal disease where an average of 10 milligrams of zinc can be lost per liter of diarrhea will present with a Bow's line. We can infer the time of the acute illness by using our ruler to measure the location of the Bow's line. So next we'll investigate the peronychium. Peronychia is the term for inflammation of the tissue surrounding the nail plate. As I discussed earlier, we can see ulceration in Raynaud's. You can also see inflammation and infection in osteoarthritis, so you might just palpate the distal interphalangeal joint or look for nodes. In an individual who is picking their nails or picking the surrounding lateral nail folds or their cuticle, you may see evidence of infection or inflammation as well. If we map those findings back to the matrix, it's in mental and emotional, because that can suggest a good deal of stress. So the final step of the exam is the capillary refill test. It's just a basic check of circulation, and it's quite straightforward. Just depress the nail bed until you see the nail, depress the nail plate until you see the nail bed blanch, and then release. Full color should return in no more than 3 seconds, and ideally 1 to 2 seconds. If you notice that the color return is greatly delayed, likely that's influencing the changes that you're seeing on the nails. Now we're going to go to the toenail exam. The toenail exam is largely the same as the fingernail exam. We're looking for the same findings. Additionally, though, we want to look for evidence of trauma. Toenail dystrophy is common because toes are housed in shoes all day long. We may see evidence of that in the first and the fifth digit. We might see signs of that in the second digit if the second digit is longer than the first digit and the shoes are improperly sized. Gait issues can contribute to toenail dystrophy. And if we see signs of changes, take a look at the shoe and see if there's an uneven wear pattern. We want to do the capillary refill test in the toes, again, because this is the distalmost point in the body. So same kind of thing. Press the nail plate until blanched, release, and it should be within 3 seconds, ideally less than that. Feel the temperature of the foot. Notice if there's excess sweating. Look for signs of infection. It's housed in a shoe, so it's a hot environment that's ideal for anaerobic bacterial growth or fungal growth. If you identify something suspicious, take a scraping. Look for hair distribution. You want to look at the overall musculature or the shape of the foot. When you're done with this portion of the exam, you're in a good position to start with your peripheral neuropathic exam.